Welcome to the deep dive. Today we're looking at something pretty familiar, emergency contraceptive pills, or ECPs. You know, things like levonorgestrel, ulipristal acetate. They're seen as this vital safety net, right? When regular contraception fails or isn't used, really important. Okay, let's unpack this a bit. We know ECPs are safe for that one-off emergency, but what if they start being used more frequently? That's our mission today. Digging into the less talked about side of things, the risks of using ECPs often, including some, rare but significant effects like ovarian hyperstimulation, and how medical imaging actually helps us see what's going on.
That's exactly right. ECPs, fundamentally, they work by delaying ovulation, mostly, or sometimes by changing the lining of the uterus, the endometrium, making it less receptive. And it's interesting, the World Health Organization guidelines, they technically say you can use more than once in a cycle, but, and this is a big but, they also warn that relying on them routinely, that can lead to more side effects. And crucially, it might kind of mask the fact that maybe a regular ongoing birth control method is what's really needed.
Right, distinguishing that emergency use from like a pattern.
Precisely.
So if occasional use is generally fine, what are we actually talking about when we say frequent use? What are the common impacts maybe people don't expect? And then what are the really unexpected things?
Well, the common things first. Menstrual cycle changes are pretty high up there. Our sources suggest nearly 1 in 5 people, it's about 20%, might see their cycle shift by more than a week.
Wow, more than 7 days. That's quite a shift.
It can be, yeah. And maybe 2% notice some spotting. Then there's evidence the uterine lining, the endometrium, can get thinner with repeated doses. You might see on an ultrasound it measures, say, 6 to 8 millimeters thick when normally be more like 10 to 12. These are usually temporary changes, but still noticeable shift.
It really makes you pause, doesn't it? Thinking a quick fix doesn't have these ripples. But okay, beyond those shifts, what's the big one? The significant, even if rare risk people should know about with frequent use.
Right, that takes us to something called ovarian overstimulation. Now, usually you hear about ovarian hyperstimulation syndrome, OHSS, with fertility treatments. But there are actually case reports linking frequent ECP use to a similar kind of overstimulation. It's rare, definitely rare.
Okay, so what does that actually look like if someone were to have this happen?
On a pelvic ultrasound, what we might see are things called functional ovarian cysts. These are normally benign, part of the cycle.
Yeah.
But here they can get enlarged. You might see multiple follicles, maybe even some fluid buildup in the abdomen. Doctors call that ascites.
Sites, right. That sounds serious.
It can be. So if someone's using ECPs frequently and starts getting, severe abdominal pain, persistent bloating, feels nauseous, or gains weight rapidly, those are signs.
Important warning signs.
Definitely. That's when getting an ultrasound quickly becomes really important to check for significant cysts or maybe early signs of OHSS.
And imaging is key here, you're saying.
Absolutely crucial. Transvaginal ultrasound is usually the first step. It lets us really see the uterine lining, check its thickness and pattern, and look closely at the ovaries for those cysts or fluid.
And you mentioned Doppler ultrasound, too.
Yeah, Doppler can help assess blood flow to the ovaries and the uterine lining. We've seen that reduced blood flow to the lining, what we call endometrial perfusion, after ECPs can sometimes link up with those cycle delays we talked about.
Okay. And if someone does develop these cysts from ECPs?
The good news is most of them tend to resolve on their own, usually within about 9 to 12 months. But if cysts hang around for more than a couple of cycles, or if the ovary looks enlarged, say over 5 centimeters, then yeah, that needs closer monitoring.
Okay, so let's boil this down for everyone listening. Key takeaway: emergency contraception. Totally safe for that isolated one-time use. But it's really, really not meant as your regular birth control. We've touched on the cycle disruption, almost 20%, seeing shifts over a week, that potential endometrial thinning, and this rare but real risk of ovarian overstimulation.
Exactly. So best practice: limit ECPs to actual emergencies. Ideally, not more than twice in one cycle. And really important, after using an ECP, think about starting or restarting a reliable, regular method. Pills, an IUD, an implant, whatever works for you. That prevents needing ECPs again.
And you mentioned the copper IUD.
Right. The copper IUD is a fantastic option. It can actually be the emergency contraception if it's inserted within 5 days. It's over 99% effective. And then you've got highly effective long-term contraception right there with no hormones involved.
That's a great point.
And talking to a healthcare provider is key. They can counsel you on side effects when imaging might be needed and help figure out that best long-term contraception plan.
So wrapping this up, what does this all mean for you listening? It's about awareness, really. Maybe monitor your cycles a bit more closely if you've used ECPs repeatedly. Notice any changes, any persistent pelvic discomfort, and definitely, if you experience those clinical warning signs, the bad abdominal pain, the bloating, nausea, rapid weight gain, don't wait. Seek prompt medical advice, likely involving an ultrasound. It's about being informed and working with your doctor for safe care. That knowledge really empowers you.